Management of multiple sclerosis requires advanced training and expanded skills from the practitioner. As advanced practice nurses, we must understand and be able to recognize signs and symptoms common in MS. This program is intended to facilitate the recognition of common neurological findings seen in MS. We'll explore the normal neurological exam and provide real-life examples of neurological abnormalities. And we'll look at several exam techniques that are useful to elicit abnormalities. It is our hope that this program will help the new or inexperienced practitioner recognize early signs of abnormalities, lending greater confidence in managing the challenges faced in multiple sclerosis.
There is no single test for multiple sclerosis. The diagnosis of multiple sclerosis is made through a combination of clinical and laboratory investigations. In spite of technological advances, the diagnosis is considered to be clinical. An abnormal history and a neurological examination with findings referable to the central nervous system lead the practitioner to order laboratory evaluations that will either support the diagnosis of multiple sclerosis or potentially result in another diagnosis. Now let's take a look at a typical assessment from the interview through the exam. The neurologic assessment begins when you first greet the patient. Much can be learned from the seemingly informal exchange. You can assess various aspects of mental status, including level of alertness, speech and language, orientation, insight, and mood. Several motor functions can also be assessed. For instance, the ability of the patient to stand up from a seated position tells us about their balance, tone, and leg strength. Posture and gait can also be assessed as you escort the patient to the exam room. Once you sit down in the exam room with the patient, the assessment continues. Now you can gather information regarding the purpose of the visit or the history of present illness. If the person is presenting with a new MS symptom, there is specific information that you need to gather. Onset of symptom, severity of the symptom, any history of similar symptoms, interventions that have been tried and if they've been successful, impact on activities of daily living, current or recent infection, location, severity, or character of any pain. During this face-to-face interview, more can be learned about the patient's mood and cognition by assessing eye contact, facial expression, and listening to the organization and content of his or her speech. In addition, you can assess facial symmetry, gross hearing, and upper extremity function. The next step is the neurologic examination, and it is used to support what you have already learned through the interview. The order in which you perform the neurologic examination is not critical, although most practitioners begin with the assessment of cognition and mood during the interview and then move on to the cranial nerve exam. These are the cranial nerves and their functions. The olfactory nerve controls your sense of smell. The optic nerve controls visual acuity. The oculomotor nerve controls eye movements as well as pupillary constriction. The trochlear nerve controls eye movement down and in toward the nose. The trigeminal nerve controls sensation on the face as well as the muscles of mastication. The abducens nerve controls lateral eye movements. The facial nerve controls the muscles of the face as well as taste on the front of your tongue. The acoustic nerve controls balance and hearing. The glossopharyngeal nerve controls sensation in the throat as well as taste on the back of your tongue. The vagus nerve controls the muscles of your throat and larynx. The spinal accessory nerve controls your sternocleidomastoid muscle and your trapezius. The hypoglossal nerve controls the movement of your tongue. Although the first cranial nerve is the olfactory nerve, it is usually not formally tested unless the patient specifically complains of trouble with smell. So usually we begin with an assessment of visual acuity. You can use a NIR card or a Snellen wall chart if one is available. The examination of visual fields can be accomplished by asking your patient to cover one eye and to look straight ahead. You then flash one or two fingers in the 4 visual quadrants and ask the patient to identify the number of fingers shown. In multiple sclerosis, optic neuritis is often a reason for decreased visual acuity in one eye. The patient may note the vision in the affected eye looks as though he or she is looking through a screen or through water. The patient may report that the vision is dim or has reduced color, Red in particular often seems pale or washed out. Examination of the optic nerve is done with an ophthalmoscope. You should be positioned so that your eyes and the patient's eyes are at approximately the same level. Ask the patient to look straight ahead. When looking at the right optic nerve, you should look through your right eye. And when you're looking at the patient's left optic nerve, you should use your left eye. The ophthalmoscope should always be between you and the patient. In multiple sclerosis, a likely cause of abnormalities of the optic disc would be the result of acute inflammation from optic neuritis. A normal optic nerve will look similar to this photo. In contrast to the normal optic nerve, in acute optic neuritis, the optic nerve can look red or inflamed. Weeks to months following an episode of acute optic neuritis, the optic nerve can become pale, as shown here. Pupil response is assessed next. In the normal exam, the pupil should immediately constrict when exposed to bright light. It may relax slightly. Following an episode of optic neuritis, the pupillary response may be abnormal and may remain so indefinitely. In extreme cases, the affected eye will dilate rather than constrict with light exposure. This abnormality is known as an afferent pupillary defect, or APD. Eye movements are examined next, comprising cranial nerves 3, 4, and 6. You should ask the patient to follow your finger as it is moved in all directions of gaze. With normal eye movements, the eyes move smoothly and conjugately through all directions of gaze. Because these nerves originate in the brainstem, they are a likely target for multiple sclerosis lesions. Lesions in the brainstem alter eye movements. The most common abnormality, one considered diagnostic in multiple sclerosis, is an internuclear ophthalmoplegia, or INO. Here, you can see that there is a lag in eye movements. The adducting eye may not cross midline, and the abducting eye may show nystagmus. This abnormality will often cause double vision. It is identified by the eye that has trouble adducting. So if the abnormality occurs when the patient looks to the right, it is known as a left internuclear ophthalmoplegia. Gaze-evoked nystagmus is nystagmus that is apparent only when the patient looks up, down, or to the side. It can be caused by various drugs, including ethanol, barbiturates, or antiepileptics. In multiple sclerosis, this is most commonly seen as a result of cerebellar or brainstem dysfunction. Cranial nerve 5 can be assessed by testing sensation in the 3 trigeminal distributions. You may occasionally find weakness in the muscles of mastication as well. Cranial nerve 7 is assessed by looking at facial symmetry, movement, and the ability to close the eyes. A peripheral facial nerve weakness, or Bell's palsy, is demonstrated by weakness of the entire side of the face, including the eyebrow and forehead. A lesion in the brain itself affecting one side of the face will most commonly spare the eyebrow or forehead. Cranial nerve 8 is checked by whispering or rubbing your fingers in front of your patient's ear. If any abnormalities are noted, further evaluation by an auditory specialist is warranted. Cranial nerve 9 is tested by checking for a gag reflex. Cranial nerve 10 is assessed by asking the patient to say ah, with the mouth wide open and tongue extended. If the vagus nerve is affected, the soft palate will not rise on the affected side. The uvula will then deviate to the unaffected side. Cranial nerve 11 is assessed by checking the strength and mobility of the neck and shoulders. The patient is asked to turn his or her head to one side, then the other, and to hold it while you push against the head in the opposite direction. The shoulder shrug tests the trapezius muscles. Cranial nerve 12 is assessed by looking at tongue mobility. With an abnormality, the protruding tongue will deviate to the unaffected side. In upper motor neuron disease, the tongue may show fasciculations and will deviate to the unaffected side. The next step is often the examination of mobility and strength in the arms and legs. The first observation should be a general look at muscle bulk. When checking strength and mobility, tone is also assessed. Muscle strength testing should include the deltoids, triceps, biceps, wrist flexors, and finger extensors. Hand grip can also be assessed. In the legs, hip flexors, knee flexors, and extensors, ankle flexors, and plantar flexors should be tested. Muscle strength is scored on a 0 to 5 scale, 0 being no movement at all, 1 being trace mobility, 2 movement without gravity, 3 movement against gravity, 4 movement against gravity and resistance but not with full power, and 5 full power against resistance. In multiple sclerosis, weakness can occur anywhere, but it is most often seen distally in the arms, in finger extension and wrist flexion. In the legs, weakness is most commonly noted in the hip flexors, hamstrings, or plantar flexors. Less obvious weakness may be noted by testing for pronator drift in the arms, or observing decreased arm swing while walking, or difficulty standing on one foot. Cerebellar function is tested in a variety of ways, and some can be done with the patient still seated. Finger-nose-finger testing will reveal ataxia as well as weakness. Rapid alternating movements can be tested by having the patient slap the dorsal and palmar surface of the hand on the anterior thigh. In multiple sclerosis, it is common to see slowed, rapid alternating movements, difficulties with finger-nose-finger, and heel-to-shin testing, as well as clumsiness with attempts at purposeful movement. Deep tendon reflexes can also be assessed with the patient in the seated position. Reflexes to be tested include the triceps, biceps, brachioradialis, patella, and Achilles tendon. The biceps and brachioradialis reflexes are mediated by the C5 and C6 nerve roots. The triceps reflex is mediated by the C7 and C8 nerve roots, predominantly C7. The patellar reflexes is mediated by L3 and L4. The ankle jerk is mediated by the S1 and S2 nerve roots. As with strength testing, reflex testing is scored on a 0 to 5 scale, 0 being no muscle contraction, 1, trace contraction when the muscle is palpated, 2, a normal response, 3, hyperactive reflexes, 4, hyperactive reflexes with unsustained clonus, and 5, hyperactive reflexes with sustained clonus. Pathologic reflexes, such as Babinski's sign, should also be looked for. In multiple sclerosis, reflexes are usually exaggerated or brisk. Ankle clonus is common in multiple sclerosis, as is Babinski's sign, which is when the great toe goes up and the other toes flare when the bottom of the foot is stroked along the lateral edge and across the metatarsal joint area. Babinski's sign is indicative of an upper motor neuron lesion affecting the lower extremity in question. Clinically, there are two major somatosensory pathways that are examined. The first is a small fiber system, which includes pain and temperature sensation. The second is a large fiber system, which controls vibration, proprioception, and discriminatory or integrative sensation. Pinprick testing can be used in the extremities and can be used to check for a sensory level. A sensory level is valuable in determining if there is spinal cord disease. The sensory level found on examination is usually 1 or 2 spinal cord segments below the actual spinal cord lesion. A sensory deficit from a spinal nerve lesion will be in a dermatomal distribution. A sensory deficit from a peripheral nerve lesion will be in the distribution of that peripheral nerve. A sensory deficit from a polyneuropathy will have a stocking and glove distribution because the longest axons are the most affected. Sensation to cold temperature can be accomplished using the rounded end of the tuning fork. This tends to be cool to the touch and can be placed lightly on the patient's arms or legs to assess cold perception. One side should be compared to the other. Vibration sensation is assessed using a 128 Hz tuning fork. The tuning fork is tapped lightly and placed over a finger or toe. One side is compared to the other in terms of intensity of vibration, as well as time until the vibration is no longer felt. Most patients describe the sensation as a, quote, buzzing sensation. Moving the fingers or toes up or down while the patient has his or her eyes closed can assess proprioception or position sense. The movement should be slight, with the digit held lightly on either side. Once you have completed all seated examinations, gait can be assessed. The patient should be asked to walk both away from you and towards you while you observe for balance, arm swing, height and symmetry of the shoulders and hips, width of base, smoothness of arm and leg movements. In multiple sclerosis, a variety of gait disturbances can be observed. The next few patients that you see will demonstrate various gait abnormalities seen in multiple sclerosis. Overall, when a patient has weakness on one side, they will tend to drift toward that side as they walk. The step and stance time on the affected side will be shortened so that the stronger side is allowed to prevail. In this patient, we see significant ataxia with head titubation. Her gait is very wide-based in an attempt at stability. She tends to drift toward the left, indicating some left-sided weakness. Her arms flail in an attempt to maintain balance. This is an example of a hemiparetic gait with left-sided weakness. She has increased flexor tone in the arm and weakness in the left leg. The leg is externally rotated with foot dragging, hip hike, and circumduction of the left hip to avoid tripping over her dropped foot. This patient shows subtle scissoring of her gait, usually left in front of right. She is mildly ataxic and demonstrates difficulty in turning. This gentleman shows left-sided weakness with shortened stance time on his left foot and a compensatory shift in his left trunk. He is unable to stabilize the left hip for balance, so his center of gravity is shifted to the right. His gait is also very stiff. This woman shows weakness on the right side with decreased arm swing. She tends to drift slightly to her right, again due to right-sided weakness. Abnormalities in strength or coordination can be demonstrated with abnormal tandem walking as shown here. Following assessment of normal gait, you should also look at tandem gait, heel walking, toe walking, and standing or hopping on either foot. Impaired balance as well as weakness may manifest as difficulty walking on tiptoes or heels. Walking on heels is the most sensitive way to test for weakness in foot dorsiflexion, while walking on tiptoe is the best way to test for early weakness in foot plantar flexion. Although technically a test of proprioception, it is appropriate to check for Romberg's sign at this point. The patient should be asked to stand with feet together, eyes forward, arms against the sides. The patient is then asked to close his or her eyes. If the patient falls or loses balance, this is a sign of impaired joint position sense. Following testing of gait and station, the patient may be invited to sit down again to discuss any findings as well as any treatment plans. As the patient sits down, you may get one more look at balance and leg strength. Normally, a person lowers to the chair in a smooth, coordinated manner. If your patient flops into the chair, it may be an indication of hip or leg weakness. A person who sits awkwardly and loses balance may have truncal ataxia or weakness. A final word about assessing a patient who uses an ambulatory device. If using unilateral assistance from a cane or forearm crutch, the device should be on the unaffected side. This allows the patient to unload the weaker leg, correct compensatory trunk lean, and restore reciprocal rhythm. Whether seeing a patient for the first time or during follow-up, an accurate history and examination are essential to diagnosis and management. Although we often focus on the laboratory results, such as MRI, LP, and EPs, they are only supporting evidence. Multiple sclerosis remains a clinical diagnosis, and the history and neurological exam which you provide are critical to accurate and complete assessment of the patient.